Good morning. Thank you for joining us today. My name is Dr. Chris Conley. Today we're going to talk about permanent impairment examination for spinal ligament injuries and joint injuries. We have a lot of information to cover today, so let's get to it. First of all, I want to say thank you to the people at VMA, Vertebral Motion Analysis, for having me here today. The VMA reveals spinal injuries and instabilities that may not be visible on standard X-rays or MRI. Functional radiography is the future when it comes to injury diagnosis to be able to give better treatment to our patients. Doctors don't use MRI to see how your eye is functioning, just as doctors don't use MRI to see how your ligaments or joints are functioning. Functional radiography is game-changing for the diagnosis of ligament and joint injuries. I've done impairment ratings for over 20 years. I've also done functional radiography for over 20 years. This is a paper that I wrote in the American Journal of Pain Management back in 2005 that outlines the things I'm going to talk about today. Anyone that would like a copy of this paper, please reach out to me. These are today's objectives. We're going to go over the potential anatomical causes of pain and dysfunction after traffic collisions. We're going to understand some of the methodologies and principles of impairment ratings. We're going to touch on injury causation and tolerance for injury and mechanism of injury. We're also going to go over the pathophysiology of ligamentous injury, specifically the viscoelastic properties of ligaments. We're going to go over some of the testing seen for ligament injuries such as VMA, DMX, CRMA, nerve testing, and MRI. And we're going to talk about the consequences of joint and ligament injuries such as post-traumatic arthritis. These are some of the takeaways from today's presentation. The typical spine has over 120 muscles, 220 ligaments, 120 joints including 97 synovial joints or facet joints, and 23 discs, and 31 pairs of spinal nerves, a total of 62 nerves. The past history, current history, signs, symptoms, physical examination, treatment, incidental findings, degeneration, diagnostic testing are all part of the clinical correlation. Don't make it about the medicine and testing. Be part of the story. Focus on what's actually wrong with a patient. A good thing I like to say is a good diagnosis is the first step to a great treatment. Pain is complicated, multifactorial, and individual for each patient. When it happens to you, it's real. When it happens to someone else, it's questionable. So that's why it's really important to document things as best as possible through subjective and objective findings. An accurate diagnosis is important to keep in mind, but also remember that patients don't have an anatomical diagnosis in about 80% of cases. Sit and talk with the patient. Talking with the patient is essential. And focus on treatment, not necessarily just the testing. Focus on what treatments are helping the patient get better. There's often a lot of questions about impairment ratings. What are they? What are they used for? These are 5 aspects of impairment ratings. Number 1 is to validate and confirm the diagnosis and recommend additional care and testing if needed. Number 2 is to go over injury causation. Sometimes apportionment's needed, but injury causation is part of impairment ratings. Number 3 is to determine the loss. What's been taken away? What's no longer there that was there before the injury? Number 4 is to talk about the functional disability caused by the impairment. Number 5 is to discuss the natural history of the disease process and future problems. This is a direct quote from the AMA guides. One can usually anticipate the future functional decline based on the natural history of the disease process, which is generally established in the literature. We're going to now cruise through some studies I think are important to get a big picture concept of things. But approximately 75% of patients involved in traffic collisions will heal within 2 to 3 months of injury. About 12 weeks. These patients have injuries to their muscles and ligaments, but not to their disc or facet joints. The 25% of patients who have progressive symptoms typically have injuries to the ligaments, facet joints, or disc. Facet joints are the most common cause of neck pain following motor vehicle collisions. A 30-year study found that 40% of patients regained nuisance symptoms and 15% have significant symptoms that require ongoing care. 23% of patients injured in motor vehicle collisions have pain for more than 7 years. So this is a problem. This was a large study that found that up to 50% of people who have motor vehicle collisions never fully recover. The National Institute of Health found that absent of macroscopic identifiable tissue damage, the facet or zygapophyseal joints are the most common cause of continued pain. Now the facet joints are synovial joints, and they have all the characteristics of other synovial joints such as the knee and the shoulder, and we have 97 of these in our spine. And what they found in this study was that 12% of all cases of osteoarthritis was triggered or caused by trauma. So facet joints can degenerate after trauma just as the knee or the shoulder can. This is one of my favorite studies on facet capsular ligaments and cause of pain after motor vehicle collisions. And what I found was really interesting is that they are the most common cause of pain. It takes the least amount of force to rupture these ligaments, but also you don't have to have complete rupture to have pain. It only takes 14% of the total energy required to completely rupture the area to cause dysfunction and pain. Also, what they found in this study was that after sub-trauma or sub-failure loading, that these ligaments undergo degenerative changes and also have increased laxicity and decreased stiffness, leading to osteoarthritis. So the stretching of the capsular ligaments causes the instability of the joint. The instability of the joint later causes adhesion, scar tissue, and arthritis. So this is a study I have. Anyone who wants, just reach out to me, or also just look it up here, the Journal of Biomechanics. It's one of my favorite studies. This was an interesting study that was done with MRI and persistent symptoms. And what they found was, in conclusion, MRI is not the answer to the diagnosis in a vast majority of patients that have developed long-lasting pain after whiplash injury. And early MRI scans do not predict prognosis. It may be relevant to focus future trials on imaging of the upper cervical spine, including functional imaging. And I find this to be very accurate, but also the study shows that long-term, the initial MRI findings often are just incidental, but not characteristic of the facet pathology or ligament pathology. I could spend hours talking about post-traumatic arthritis and the pathogenesis of it. This is a great paper that anyone who's interested should read more about it. And it goes into great detail about the pathophysiology of osteoarthritis and joint instability after trauma. So this is important that the functional changes that occur due to the initial primary tissue damage result in secondary tissue damage that over time cause degeneration, deterioration of the spine. So degeneration, arthritis, instability is very common, but we don't see these until far removed after the trauma. It's important to recognize that many of these severe interarticular injuries, ligament injuries, is the beginning or the start of a chronic disease process that leads to degeneration and arthritis. But understanding the pathophysiology is important because then you can develop better treatment mechanisms to help reduce the secondary effects and increase joint health. So why is it important to understand joint injury and ligament injury? Because spinal injuries are directly linked to the number 1, 4, and 6 leading causes of chronic pain and disability in the United States. And this is important because if we get the patient the diagnosis and proper treatment, we could reduce the long-term effects of these injuries, giving a better chance not to develop into chronic pain or disability. Before today, how many of you knew that we had 120 joints of the spine? We have 23 discs, which are symphysis joints, and 97 synovial joints or facet joints. The synovial joints have nerves, meniscus, cartilage, synovial fluid, and a joint capsule. There's also a synovial fold that gets into the joint that often could cause pain as well. But this is important because we focus too much on the MRI and not on the facet joints, which is shown to be the most common cause of pain, but we tend to focus mostly on the disc. But the facet joints are a very common cause of pain. Also, they're synovial joints, very similar to the knee or the shoulder. So if you have 97 of these in the spine, and you could actually tear the meniscus, you could actually tear the joint cartilage, you could tear the cartilage of the joint surfaces. This is a very important area to recognize because it's a common cause of pain, but also long-term can cause arthritis and dysfunction. We tend to overlook the facet joint as the cause of pain in many cases, but we just completely ignore the ligaments. So if you look here, this is a good demonstration of all the ligaments in the spine. We have 220 ligaments and 120 muscles. So ligaments provide stability. They also are pain receptors, and they're important because of the fact they're more commonly injured than the disc, but they're often overlooked. So this is a great example of the different ligaments that we have in the spine. And then when you're doing an analysis, and even on MRI, you could see these, but it's often overlooked, you could actually see ligament tears. And I'm going to show a couple samples in a second. But Don't forget the ligament injuries. We have 220 ligaments in the spine, and they're very, very important. The upper cervical spine has no disc and is all ligaments. They also have facet joints as well, but doing an MRI only to a person who has neck pain and continued neck pain or headaches is forgetting the fact that there's no disc in the upper segments of the spine. So functional radiography and a good clinical examination is very important to determine if the pain is coming from the upper cervical ligaments and facet joints. Remember that facet joints are synovial joints. All synovial joints have the same features: synovial fluid, articular cartilage, a joint capsule, synovial membrane, ligaments, blood vessels, sensory nerves. These are important because of the fact that these all make the characteristics of the synovial joint. Sometimes they also have internal or interarticular disc and meniscus. In the case of the facet joint, it does have a synovial fold and often a meniscus, labrum, fat pads. Facet joints also have fat pads, bursa, and synovial plaque. This is just another picture of the facet joints showing the joint cartilage, showing the subchondral bone, the articular capsule, the meniscal folds. And so facet joints are synovial joints which have an increased risk of tearing, pain, dysfunction, and arthritis. Facet joints are highly integrated with nerves. So there's nerves that come from above, below, and the same level of the facet joint. So there's a lot of nerves that go to the facet joint, even into the capsule. You'll see here that it actually goes into the synovial fold. So those nerves go into the tissue, which make it very pain sensitive. Think about the pain sensitivity of your fingertip. The more nerves there are, the more likely you're going to feel pain. So the capsular ligaments have a high density of nerve fibers which help with pain, but also they're very important for proprioception and balance. There's some variability in the facet joints. Some patients have meniscus and some patients have synovial folds. It's important to compare and contrast muscle injury versus ligament injury. So muscles are involved in movement. They have lots of blood supply, so they heal very well. They're red because of their rich blood supply. They're rarely involved in chronic injuries. They're very large, so their size is in feet. So they're very big as far as the relationship to the body. The relationship to the joints are outside the joints, and they have good stretchability. So they actually have excellent blood supply, excellent healing potential, and good stretchability. Ligaments, on the other hand, are for stability. They have poor blood supply. They heal very poorly. They're often the cause of chronic pain. They appear white because of the lack of blood flow, and they tend to be small. The relationship is usually inside the joints, and they insert into the bone. They have poor stretchability, and they have poor healing potential. So in general, muscles have lots of blood supply, good healing potential, and they tend to stretch or respond to trauma very well. Ligaments, on the other hand, are for stability. They have poor blood supply. They tend to heal very poorly, and they have poor stretching ability, poor elasticity. So they're a more common cause of collision-related injuries. It is important to recognize that ligaments are also a sensory organ and very much responsible for balance, proprioception, and vestibular functions. Oftentimes, I get from adjusters or attorneys, it's only a soft tissue injury. Well, so is the heart, so is the brain, so are the lungs, so are the eyes. It'd be difficult to live without these things. So soft tissue injuries tend to heal and have more long-term problems than hard tissue injuries like bone. This shows the density of tissue and fragility of tissue. As you can see, bone, it takes a lot of force to damage and has good healing potential. The brain and other soft tissues such as muscles, ligaments, and joints tend to take less force to injure. So this is the tissue strength and fragility of areas. I do a lot with brain injury, and as you see, the brain is the most fragile of all the different tissue types in the body. Another great study showing capsular ligaments have a high risk of injury, particularly at low force collisions. This is saying that 3.5 Gs and higher have an increased likelihood of damaging the facet joints. This is another topic we could spend at least another hour on, which is the viscoelastic properties of ligaments. But the same is true with the brain tissue as well. So what happens is with viscoelastic properties, it gets slowly deform over time. Rapid forces, shearing forces, rotational forces can actually cause damage very quickly. So think of Play-Doh. If you stretch it slowly over time, it stretches nice and deforms. If it's very sudden, quick, or if there's shearing forces, it'll actually break. Remember we talked before about it only takes about 14% of the forces to cause failure of the ligaments to actually cause deformation, pain, and permanent damage. In this study, they used video fluoroscopy during collisions. They analyzed the motion of the facet joints. They found the facet joints jammed together, causing interarticular damage, meniscal damage, and facet capsular ligament tears. Having the head turn prior to the impact pre-torques the facet joints and increases the risk of injury. Another reason why the facet capsular ligament is a common cause of pain in the cervical spine is because the multifidus muscle actually inserts into the capsular ligament. This is very unusual. Most muscles insert into bone, but in the cervical spine, the multifidus inserts into the joint capsule. So if a muscle goes into spasm or has trauma related to a motor vehicle collision and that muscle tightens, that's going to pull on the capsular ligament. When it pulls on the capsular ligament, it has an increased risk of damaging that capsular ligament. I'm not going to go into this too much, but I just wanted to show you that the interspinous ligament, ligamenta flavum, capsular ligament, PLL, and ALL all have been tested about the forces to cause injury and pain. And so each one has a different threshold, but they all work together and all are potential causes for pain and dysfunction. Same with the upper cervical ligaments. The upper cervical ligaments are essential. They tend to be missed in a lot of cases with persistent headaches, overlapping sometimes brain injury. So don't forget about the upper cervical craniovertebral ligaments. This is very, very important. Just like with other ligament injuries, there's different grades of injury. So we have normal, grade 1, grade 2, and grade 3 injuries. And these are often found on physical examination to determine the grade of injury. Just like ankle sprains, these capsular ligament injuries can be graded according to severity. As you can see here, ligament injuries can cause a wide spectrum of symptoms and problems. And it's important to differentiate the ligament injuries from the disc injuries. But this is a great example of some of the things you could see typically with ligament or facet injuries as well as disc injuries. But the disc is tough. You know, we like to think of the disc as a jelly donut, but in reality, it's hard like a piece of chewing gum surrounded by a tire. So it takes a lot more force to injure a disc than it does to injure the ligaments. Each tissue has a different expected healing time. So that's why it's important to grade the ligament injuries to be able to say, okay, this is normal within this type of injury. It's also important to realize that interarticular damage to the capsular ligaments that cause problems within the facet joint, they don't heal very well. So articular cartilage repair could take up to 2 years and in most cases don't heal very well at all. It's also important to realize that each patient's different and has different potential for healing as well. So every patient's different. This was an interesting study showing the different tissue damage and the normal healing potential. It's important to note that interarticular joint damage was unlikely to heal. So it talks about the different grades of ligament injury, tendon injury, muscle injury, but also interarticular joint injury is unlikely to heal. This goes with the previous slide showing interarticular joint injury is unlikely to heal. Articular cartilage has very limited healing potential secondary to poor regenerative capacity and avascular nature of cartilage. Just like the inner part of the meniscus won't heal, typically the articular cartilage won't heal either. This is a great representation of the different symptoms that could occur from traffic collisions, but also the different referral sources, such as the capsular ligaments, the interspinous ligaments, fractures, ligamenta flavum tears, also source of dermatomal pain such as the disc. Also, we can't overlook TMJ problems. Also, we can't overlook brain injury, and we can't overlook PTSD and anxiety. So it's really important to weed through and talk with the patient to get the best clinical workup possible to get the most accurate diagnosis. Again, the upper cervical ligaments are huge and can cause a wide variety of symptoms and often overlap TBI. So if the patient has a brain injury, also look at the upper cervical spine. In fact, most experts say that it's unlikely to cause a brain injury without also having an upper cervical injury because the forces involved for a brain injury are greater than the forces involved to cause a ligament injury in the upper cervical spine. So by default, if the forces were enough to cause a brain injury, it's also enough to cause upper cervical problems. So make sure to keep that in mind when patients have continued problems and they have a brain injury, is to also look at the upper cervical spine. Today we're talking more about joint and ligament injuries, but keep in mind that brain injury is also very common and very commonly missed. So approximately 50% of patients who have head injury aren't properly assessed or diagnosed, and about 50% don't get follow-up care. So also keep in mind that there could be other things besides ligament damage causing the symptoms. So also remember to assess for brain injury. PTSD and anxiety is very common also to keep an eye on, because 60% of people will have mild depressive disorder, 40% will have PTSD, and about 40%, 50% will have some degree of anxiety and driving phobia. So this is something important to diagnosis and also get treatment when needed. Part of what we deal with on a daily basis is pain and suffering. This is a definition that I like and use often. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such terms. I'll repeat that. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such terms. Suffering is defined as a state of distress associated with events and threatening to the intactness of the person. Suffering is also expressed as the experience of distress or disharmony caused by a loss or threatened loss of what we cherish most. So we see this a lot of times with patients who have permanent impairments, brain injuries, persistent pain, or surgery. When documenting injuries, it's important to address the subjective symptoms and signs that you may see with the patient, as well as the objective findings clinically you see in the physical examination, joint loading, as well as the MRIs, CTs, VMA, other types of diagnostic tests that you want to objectively clinically correlate with the subjective symptoms. This is straight from the AMA guides and talks about that, where you want to focus on the clinical history, the physical examination, and clinical studies. Clinical correlation, when the information provided all relates to a clinically relevant diagnosis. But this is a very important thing to focus on: the clinical history, the signs, the symptoms, the physical examination, and correlate with the clinical studies. So it's really important to sit and talk with patients. Really go over the symptoms, the signs they may have, be aware of other things such as brain injury, such as anxiety, other things that are really important to document and to realize for the patient's care. Number 2 is focus on physical examination. What are the clinical signs? What are the testing that's positive? Joint loading, where does that cause pain? Focus on the MRIs, VMA, motion X-ray, CT scans. Look at the clinical correlation with the diagnostic test, and have a team of medical providers that you can work with, that you know the patient will get the best patient care and get the best results long term. It's important to realize as well that each patient has a different tolerance for injury. Each patient has a different potential for healing as well. It's important to realize this and document it. This is the real factors when it deals with potential for injury and human factors. You have the crash factors, plus you have the human factors, and that equals the risk of injury. And as you can see, there's lots of different factors that determine if someone's going to be injured or not, but also what their likelihood of healing is going to be as well. There's a big difference between a healthy facet joint and arthritic facet joint. The top picture designates the healthy facet joint, where the two surfaces glide like two pieces of ice together, and that's actually the viscosity, like two pieces of ice, versus a arthritic bone spur ridden joint like sandpaper or glass that's in there. So when you have a trauma to the area, you have more likely of tissue damage as well as more likely pain. Spinal imaging is like a wedding photo. You can't tell who's drunk, who's happy, who's angry, or who's in pain. The patient history and clinical examination will reveal this. The same is true with neck or back pain. It's very common to have degenerative findings, bulging disc protrusions, other findings on MRI that are patients who don't have pain. But also it's important to realize that this increases the risk of pain. In fact, studies have shown there's a 2 to 5 times increased risk of pain when someone has a pre-existing degenerative condition. Disc degeneration, facet arthrosis, canal stenosis, bone spurs, all can increase the risk of injury and delay healing. This is a great example of abnormal motion on flexion and extension, and you look for spinal instability. And this is very, very important because the ALL and PLL are dysfunctional at this point and long-term cause problems and eventually will need surgery. These are some common findings in functional radiology: multi-level instability, instability above a surgical fusion, severe upper cervical instability, cervical destructure. Any patient with a previous fusion surgery should have some dynamic motion X-ray to evaluate the areas above and below the fusion after a trauma. If the symptoms in clinical examination is positive, look at the MRI and you may be able to see ligament damage on the MRI that's not otherwise noted or documented. This is an example of such where I found that the ligaments in the upper cervical spine were damaged and you could actually see on the MRI. The same is true with disc pathology. If the symptoms are there and the signs are there and the clinical examination shows it's a disc pathology, look on the MRI. And it's important because in that way, when you're able to take pictures of these and put these in your records, it really helps to show the objective nature of the injury. It's important for the patient as well as anyone else reviewing the file. This is an example of facet capsular injury seen on dynamic motion X-ray. With oblique flexion, you could see the capsular ligaments and see how stable they are. In this case, you could actually see the tearing of the ligaments. Vertebrogenic or modic changes seen on MRI are very important to recognize. Many times these are dormant and a wreck or collision could actually cause this to be symptomatic. Intercept procedure is a wonderful procedure that is diagnostic and therapeutic, which helps the patient get great pain relief, but also diagnostic that it was the vertebrogenic pain causing it. But it's also important to recognize that these are rateable under the AMA guides for impairment rating as a permanent loss or permanent dysfunction, and long-term will accelerate the arthritic process. We talked at length about facet problems, facet injuries, medial branch blocks, and RFAs are diagnostic and therapeutic, that the pain generator is the facet joint. Again, these are rateable under the AMA guides for impairment rating. So with facet joints, we have medial branch blocks, RFA, inarticular facet injections, we have PRP injections. These are all helpful for the symptomatic relief, but it's also important to realize that this is something that long-term the joint will deteriorate. So I like to use the example of a cracked tooth. If you have a cracked tooth and you deaden the nerve to the tooth, that didn't fix the tooth, that just deadened the nerve. So the same thing with a facet joint is if you have a damaged facet joint and it's inarticular, that is something that long-term it's going to degenerate and cause problems down the road. The injections are helpful, but they don't fix the actual joint damage in the facet joint. So it's commonly acceptable that we talk about diminished value to the vehicle after it's repaired. But it's important to also talk about the diminished value to the body after the body is injured. And that's where impairment ratings come in to help to quantify the loss. The AMA Guide to Injury Causation and AMA Guide to Impairment Ratings are essential to have if you want to do these impairment ratings. But it's also important to realize that the AMA Guides has went to a digital living version that basically is updated every year. So it's important to get the most current edition online. The AMA Guide 6th edition was written in 2007, but it was updated last year online, so the online version is the most current version. The AMA Guide specifically says part of the impairment process is determining causation, and there's an entire process to this, but it specifically says causation should be done by doctors who evaluate all of the information, and this is important to know. There is a 5-step process for doing impairment ratings. One, you want to determine what the permanent loss is. What's the diagnosis? What's the reasonableness and apportionment, and what is causation related to the injury? Determine the appropriate chapters and related tables and guides for the loss. Calculate the percentage loss on the whole person basis, and then discuss the natural history of the disease process. What does the future look like? But a major premise of impairment ratings is that any other observer or physician following the methods of the guide should evaluate the same patient and should get similar findings. An impairment is a loss of use, or derangement of any body part, organ system, or organ function. An example I use is a car. If you go to the parking lot and someone steals your tire, that's a loss. It was taken away from you. The disability is the effect of the impairment on the car or the body. So you could actually drive the car, but that's going to cause more damage. But the impairment is the loss or what was taken away. An impairment rating basically helps to tell the patient's story. How are they different? What have they lost? What did they overcome? How are they different functionally, occupationally, recreationally? And how has it affected their dreams? This is a big picture view of a serious injury, such as a brain injury, facet injury, disc injury, things that may need surgery, multiple injections, chronic pain. But first of all, you want to look at the signs and the symptoms. Then you look at the diagnostic testing. Do the diagnosis and the testing, do they support the signs and symptoms? Is there clinical correlation? What's the likelihood of incidental findings? What's the recommended treatment? What treatment did they have? Is that consistent with the said injury and diagnostic test? And then the impairment rating, causation exam, or disability exam. And lastly, you want to do the life care plan or estimate of future damages. But it's important that an impairment is a medically determined physical or mental impairment must be a result from an anatomical, physiological, or psychological abnormality which can be shown by medically acceptable clinical and laboratory diagnostic techniques. In such cases, one can usually anticipate the future functional decline based on the natural history of the disease process, which is generally established in the literature. And this is very important to realize the big picture nature of all these injuries. I know we're out of time, but thank you for listening to my presentation, and please reach out if you need anything. Have a great day.